Well, hello there, everybody. You know, it has been some time since I have recorded one of these videos for you all. And there's reasons why that may be the case. Like any of you people out there, I have many things going on in my life, but there's some extra special things that have been going on recently. And I will make those announcements a little bit later for some of you, okay? For today, I wanted to talk about Sphenopalatine ganglion, or SPG blocks. And this is a nerve block procedure that, as far as we know, if you research the history on this, has been performed since the late 19th century. And back then, it was performed just a little bit differently than it is today, and we will review that in just a few moments here. But I'd like to say that about 10 years ago or so, this became a very trendy thing to do in some headache centers and in some clinics for neurologists or other healthcare providers that had an interest in treating people with headaches and facial pain. And again, if you provide me a few moments, I will explain to you all why that was the case. And for a while there, once it started to become trendy, there was plenty of research posters and medical literature that started to be published, and a great deal of information, actually. For myself personally, I would say just before these things started to become trendy, a colleague of mine who was in charge of a headache center when I was practicing in Texas, he was the one that really made me aware that this procedure could be very helpful for my patients. And he was the one that had really mentored me and had taken the time to explain a few things about this procedure to me so that I could provide this to my patients. So I'm going to move forward here, and we're going to jump right in, and I'm going to provide the very basics and try to make this simple and to the point. So here we go yet again. An anatomy picture with tons of arrows and a whole bunch of stuff that you probably don't want to look at. But here's what I'm going to say. This is the inside of somebody's nasal cavity and their skull. I'm going to try to pull up a pointer here, okay? So if you were to pick your nose, okay, this is probably about as far as your fingertip can get, actually. Way up in the back of your nose here, behind this mucosa, okay, there are little turbinates, and your septum is not featured in this picture, but way back here in your nasal cavity, there's a little tiny fossa, a little tiny cave, so to speak. There's a very thin wall, and inside that pterygopalatine fossa is your SPG ganglion, okay? And you can see here from this picture, there's a whole bunch of nerves, okay? It's kind of like a grand central station. There's many things which relay through the sphenopalatine ganglion. And what you see here, this big fat thing, this big fat nerve, that's your trigeminal nerve, okay? Your trigeminal nerve controls most of the painful nerves of your face and your nasal cavity and your skull. And some of that relays right here through the sphenopalatine ganglion. So the idea here is, if you could anesthetize that ganglion somehow, could you provide relief of headaches and facial pain and those types of things? My experience has been that this is most useful for, you're going to have to look down the corner at my horrible camera, sorry, more useful for around the maxillary areas, okay, the cheeks, and around the orbits and upper foreheads, okay, for pain in those areas. There's some argument it may be helpful for pain in other areas as well, okay. Overall, as I said earlier, the idea to anesthetize this ganglion has become a concept that has actually provided quite a bit of relief for a number of people. How exactly do you anesthetize this area? Well, that's a different story that we are about to march into. The only other thing I would say about this ganglion is, other than having some pain nerves relate to this area, this is an autonomic ganglion. So things such as your lacrimal glands, your tears, and those types of things also have pathways that pass through here. This is why when you irritate your nasal cavities, okay, if you've ever jumped into a swimming pool and all the water rushed up your nose, or if somebody made you laugh while you were drinking through a straw and regurgitated your drink through your nose, this is why you feel that irritation up here around your eyes and your eyes water, okay? So if you observe this picture here, this cotton-tipped applicator, okay, basically it's just a very long cotton swab. When you buy these things from medical supply companies, they're about 6 inches in length. The idea was that you place this into the nostril, you aim it about 90 degrees towards the table. This person is laying on a table and their head is typically flexed backwards, okay? And what you see here along the middle of the nose, the medial side, okay, not this way, but this way. Again, there's your nasal mucosa, and there are these turbinates. If you slide the shaft of this applicator right across that middle turbinate, right, and you can place the cotton tip right along this very, very thin wall that overlies your pterygopalatine fossa, which contains your sphenopalatine ganglion. So the idea here is, if this applicator is soaked with a local anesthetic and you place it here and wait anywhere from 10 minutes to 30 minutes, that some of this anesthesia will diffuse into that fossa and anesthetize the ganglion and thereby provide pain relief. This is a very, very simple procedure. However, you can see the dilemma from this very easily. The dilemma here is the following. While doing this does not require the physician to pull out a big, long needle, and you're not going to get stuck with the needle, placing things in your nose is not fun. I myself have attempted this procedure on myself. Pause, go ahead, laugh at that. And the reason why I wanted to do that was to see how far I could actually place this cotton-tipped applicator up my nose, because I did want to appreciate what my patients go through, okay? And it is a little bit irritating. As I said in the previous slide, when you get things up your nose, water and those types of things, it does feel a little bit irritating, and it will make your eyes water and those types of things. So it can be a little bit uncomfortable from that sense. And of course, everybody's nostrils are a little bit different. Some people have deviated septums, some people have nasal polyps, so you can irritate people very easily. For some people, that cotton-tipped applicator does not pass very easily for those reasons. So while it is a very simple procedure to perform, it can be a little bit annoying, but it is highly effective, and I will say that. Now, going back to the history of this procedure again, the first procedure that was performed, or at least recorded in history in the late 19th century, they actually soaked their applicator with cocaine. And in some of the European articles that I reviewed and read about this procedure, they still may use some cocaine. Will that work? Yes, it's very, very effective, but obviously we don't use it for obvious reasons, okay? We use local anesthetics such as lidocaine and marcaine, or the generic name Pivocaine. When I first started to do this procedure on my patients, even though it was a little bit nerve-wracking to think that I could be causing my patients a little bit of nasal discomfort, I'll admit it was very, very effective, very simple to perform, and very, very helpful for my patients. So I was happy to see at least the results that my patients were receiving from this procedure. So I really started to research this procedure in quite a bit of detail. And the reason why I had done so because I asked myself, there's got to be a better way to do this. Really, there's just got to be a more simple way to do this to patients that is not as nerve-wracking. Okay, most people do not enjoy placing cotton swabs very deep into their nasal cavity, even though it may provide quite a bit of pain relief. Most people do not enjoy this, so there has to be a better way. And I took an incredible amount of time to research this on my own, and I came up with a method that I thought was very, very effective. And the method that I adopted from one of the European articles that I had reviewed was to actually place a piece of tubing or catheter tubing over the shaft of the cotton-tipped applicator, and at the tip of that tubing, a little connector device for a syringe, so that every few minutes or so you could come into the room and squirt some additional local anesthetic down the shaft of the tube, right? Well, let me back up and restate that. You could deploy the local anesthetic through the tubing that was over the shaft of the cotton-tipped applicator, and so it would eventually go down to the tip and re-soak the tip all over again, thereby applying additional local anesthetic to the patient's painful areas, okay? And while that was very, very effective, and more effective than just using the cotton-tipped applicator soaked in anesthetic alone, it still required you to place a long cotton swab down somebody's nasal cavity. So I thought, well, is there a better way? And I came across some devices that were available. And the first device here, this TX360, is what I came across. I'll explain how this is used in a few moments. And then there were some other devices, these catheter devices, the Sphenocath, and this one over here, this blue thing, this is the a device called the Alivio. Please notice how the Alivio and the Sphenocath are very, 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 let's add an infinite amount of Aries, similar. Just take note of that for a moment. But the idea of these devices were, the individuals who developed these devices felt as if they could provide a way to anesthetize the sphenopalatine ganglion in a more comfortable manner. So I was fascinated by this. I had researched this a little bit further, and these devices suddenly hit the market. And as I said, I'd say about 10 years ago, suddenly everybody who had an interest in headaches and facial pain was suddenly using these devices, and they became the talk of the town, so to speak, okay? I'd spent much time discussing the use of these devices with colleagues. However, here was the drawback. These devices are very expensive. They cost quite a bit of money to use these devices. So the downside here is this. The Sphenopalatine block is controversial with your health insurance. Many health insurance companies do not want to pay for this procedure. So unfortunately, some of the clinics that were providing these procedures, they would go spend, say a couple $100 on these devices, perform the procedure on their patients, and then have the insurance company refuse to reimburse for the procedure. And if they made a rebuttal or kind of put up a fight, they might get $80, but yet they spent hundreds of dollars on the device. So then it became an economic disaster for people to use these devices. And interestingly, very early, again, when these things started to become hot, we were using what we call the CPT code in the medical billing world. We were using a CPT code for the sphenopalatine ganglion block as if we were doing an injection. And the argument that the physicians had was that even though these devices do not use a needle, you are still, quote unquote, injecting an anesthetic against using some type of pressurized device. So it technically was an injection. This worked for a while, but then at this point in time, virtually all of the healthcare insurances just say, no, we're not paying for an injection. And there really isn't a CPT code. So for those of you who are not in the medical profession, have no idea what I'm talking about in regards to medical billing, it has pretty much gotten to the point here where you can't get reimbursed for these procedures, even though I do feel that they are very helpful. So again, let's just back up. You spend hundreds of dollars for these devices that were nicely designed and comfortably deliver local anesthesia to the sphenopalatine ganglion, but then your insurance won't pay for it. So, you know, your clinic loses out, and many people have stopped using these devices because of that, or it's kind of fallen out of favor. At least I've noticed that. That's been my observation. These procedures and these devices are no longer the talk of the town. Okay, believe me, these were talked about quite frequently back when it became a hot commodity. So is there still the way that you can provide this procedure to your patients and not have to worry about the medical economics of it, of you losing money or the patients losing money? Because, by the way, just as a side note, and some of you probably know this, most healthcare providers, they use an outside entity for their billing. And if something does not get reimbursed, they just, you know, like a robot, they'll just automatically stick the patient with the bill. So next thing you know, you could get a bill at home for anywhere between a couple hundred, maybe even over $1,000 for something that wasn't paid for. And we certainly don't want to see that happen, okay? So, but I am going to move forward here and discuss a little bit about what you're looking at here and why these things can be a little bit helpful. But before I do, again, I want to point out to you, notice that the Alevio catheter and the Spheno catheter are very, very similar to each other. Okay, so for this TX360 device, you have the patient sitting facing you. You place this little tip in the nostrils here. You aim it towards the middle turbinate, and you end up deploying this very, very, very tiny catheter. Believe me, it's very, very tiny. The patients hardly feel anything. And then after you deploy this thing, there's a little plunger here, and you squirt just a very, very small amount of local anesthetic over the sphenopalatine ganglion, or over the mucosa that diffuses into the sphenopalatine ganglion. I will say this, the inventor of this device, so it's called the TX360, Dr. Tian Xia, he is very, very, very confident in his device. I've talked to the man personally. He has no problems standing up for his device and claiming that his device works very well, and it is very well designed. I will give him that. Very comfortable, very easy to use, but again, the downside, as I already had explained to you all, you have to spend a few $100s to just obtain the device alone. And then when your healthcare provider bills your medical insurance, the whole thing may get denied for reimbursement. So it's become a little bit of a battle. As a side note, I failed to mention this earlier. These devices are FDA cleared, okay? So the FDA has agreed that these devices are safe to use. That doesn't mean that they are FDA approved for certain headache disorders, okay? But the FDA will at least agree that these devices are safe to utilize if somebody wants to use them. Now down here, in this case, the patient is lying on their back with their head extended, and the sphenocath, you place it into the nostril right up here to until it can't move anymore, okay? Then you pull back a little bit, you deploy an inner catheter, this little hook-like catheter comes down, and then you squirt your local anesthetic. It's supposed to shower downward over the mucosa, the sphenopalatine ganglion, and the patient lies back for about a half hour, and allows that local anesthetic to work. A little more cumbersome than the TX360. Like I said, this is very quick. Sit down, in, deploy, squirt, done. Other nostril, in, aim, deploy, squirt, done. Okay, no messing around with this one. This one, it takes a little bit longer, okay? Now, I have not included a picture of the Allevio device. Remember what I said earlier? Notice how the Allevio device is very similar to the Sphenocath? Because you use it the same way, okay? It is utilized in the same manner. So there's really not any difference. I would say this, okay, so what has my experience been? Because I have personally used both methods, okay? My experience has been this. The TX360 is very quick, it's very easy, it's very well designed. The designer is very confident in his device, and he will stand up for it, okay? But I don't know if I agree that such a small amount of local anesthetic is going to be effective. Now, Dr. Cha will argue that if you aim this thing right and get it in the exact spot, it will be. I would just like to clarify with each and every one of you that that is easier said than done. Okay, these pictures make this look very simple. It's not as easy as it sounds. So I feel that bathing the area sometimes can be a little bit more effective because you're placing more volume of a local anesthetic into this area. It's pulling, and it's probably going to hit something that's worthwhile eventually, okay? And you provide a little more time for this to kind of soak and get into its area. So which method is better? I can't really state with any certainty. I feel I have had success with both methods, to be honest with you. But again, in the environment we have today, is there a better way to do this procedure that maybe is more accurate, more precise, and will be reimbursed by your medical insurance and will not cause a whole bunch of billing dilemmas for the medical provider or the patient? So you know what I've noticed? Nothing works better than the old way, okay? It might be a bit more uncomfortable than the catheter devices, but it just works better. However, well, here's the thing. When I was in discussions with other providers about what to do here, you know, this dilemma of buying these very expensive devices, even though they're well designed and they seem to be very helpful. There was a healthcare provider in Texas again, somebody a little bit different. His opinion was that those devices, okay, maybe they could be helpful, but he came up with a different way on his own of using a nasogastric tube and aiming a little bit differently. And so I started to sit back and think to myself, how exactly does this guy do this with a nasogastric tube, okay? What on earth is he doing to make this more comfortable and more effective for a patient? And again, listen, I've taken a lot of time to think this out and really explore this. So I came up with a method that was sort of a hybrid method of what other healthcare providers out there had shared with me that I think is very effective, works very nicely, and is much, much more comfortable, even more than what you see here. Why am I not sharing this with you on video, to be honest with you? How can I say this? There are some healthcare providers out there locally in my area that would love to know my secrets, okay? They would just love to know how I do this. And I'll tell you what, if you're one of those healthcare providers and you are watching this video, give me a call. I'll gladly share the information with you. I will gladly train you and show you how to do this in a very, very effective manner, in a very proper manner. Till then, if you want to try to be sneaky about it and steal my secrets and other methods, shame on you. Anyways, back to the point here. I won't take complete credit for my method. As I said, I have spent a great deal of time researching this, reading about it. I've looked over various methods from different countries and different providers and different sources of medical literature, and I came up with a way that I feel is very helpful and very effective that sort of does employ this old method, but yet will not be as uncomfortable for the patient, okay? And ultimately, my method cost pennies to the dollar compared to the expensive devices. So if your healthcare insurance does not reimburse me for the nerve block, well, I can still bill for the patient visit, and that's good enough for me, okay? I'm not going to be losing hundreds or even thousands of dollars, and you are not going to be billed hundreds or thousands of dollars, okay? So we all win with the method that I came up with. As a side note, I will say this. Could you perform these procedures with a needle? Yes, you could. Would I? No. That could be a little more dangerous. It would definitely be more effective, but it is a bit more dangerous. Yes, there are some sources of medical literature that I've come across where some individuals have rigged up a spinal needle, just like you see here with the CottonTip applicator, and got the tip of the needle into this fossa. Again, that would be very, very effective. Another healthcare provider had pointed out to me that a pudendal nerve block kit. So for those of you in the gynecology world, way up, if you place a finger in somebody's vaginal canal and aim towards the lateral part of their pelvis, you can reach the pudendal notch. And if you place a little needle tip in there, you can anesthetize their entire genital area, okay? And this is used in regional anesthesia for gyne surgeries, sometimes in childbirth as well. So somebody pointed out to me that the little pudendal nerve block kits, if you were to place one of those into the nasal cavity, you could probably get a needle into that area very nicely and very accurately. Again, I'm just a little bit afraid of using needle in that area because, again, it's a very, very thin-walled area. I'd be afraid of puncturing something just a little too close to the brain for me, okay? I wouldn't be comfortable with that. For what it's worth, if you're in the wrong place and you go through the sphenoid sinus, then you really got a problem, okay? For those of you who have not studied extensive craniofacial anatomy, trust me, that would be a real bad dilemma. There are ways to get into the Sphenopalatine canal through the hard palate, okay? Your dentist probably know how to do this better than any of us MDs or DOs. And your dentist probably, in some cases, use this for dental anesthesia when they're performing work on your teeth. But a number of dentists do not get involved in the world of facial pain. Some do, and I would say this, if you're having some facial pain issues and you want to do a Sphenopalatine block, they might actually be the people to go see. There's also, but again, for me, the reason why I wouldn't do it, I'm just not used to placing needles in the hard palate. And again, if you're not in the right area, it's just not going to work. It'll cause the patient significant discomfort, and it's not going to work. So I think somebody who places needles through the hard palate all the time should be the ones to do those procedures. Now, the infratemporal fossa, so right here above your cheekbone, okay, right here, if you take a big spinal needle and aim it kind of this way, bury it, and below, I will try to provide a link for a video that shows you that. You can use fluoroscopy and x-ray vision to see that needle tip actually get into the Sphenopalatine ganglion, into the fossa where it lives, and anesthetize the area. Very, very, very effective. Many anesthesia individuals that I know will not perform that procedure. Many interventional radiologist will not perform that procedure. I have yet to find a colleague who is willing to perform that very procedure. With that procedure, the danger is you are passing that needle through areas of high vasculature. So sometimes you cannot compress the area if it starts bleeding. So not in my experience, but a colleague had once shared with me that a patient's face really swelled up after that procedure. So for example, in your arm here, okay, if I place an IV in your arm and you start bleeding everywhere, right, we can compress the site for a while. Here, well, that's not the case. There are places very deep in here that needle passes, you can't compress the site. You have to wait for it to stop bleeding, and that can be a little bit scary. So a needle approach can be very, very, very effective and very helpful. I'm just not comfortable performing those procedures, and quite frankly, I can't say I've met anybody who is. So, but hey, if any of you out there find somebody that is, certainly let me know. So in conclusion here, below in the description, I will include a number of links where you can watch videos and see some of these things performed, and certainly have some better ideas and information about these procedures. These procedures are very, very helpful. Again, I would say for people who have lots of facial pain, okay, people who have trigeminal neuralgia, post-herpetic neuralgia. For people who have chronic migraine, once you get something called central sensitization and everything hurts and everything is sensitive, it's very effective for those individuals as well. If you're a chronic migraine patient that's tried everything, and I mean everything, you have nothing to lose by trying this procedure. And sometimes it at least provides a bridge to therapy. So I think it's a very helpful procedure. I think it's a very simple procedure. After more than 10 years now, I have mastered a way to do this that I think is a little bit more comfortable and a little bit more effective, and it's not going to cost an arm and a leg, where I am not going to lose money and you are not going to be billed money. So I think we're all going to win with this. But if you have any questions, certainly feel free to contact me.